As you begin to walk down this path of TMS, or mind-body syndrome, knowing that you're dealing with a psychophysiologic issue and that it's not a structural problem, you might be wondering why are manual therapies, physical therapy, stretching, body work, why are those still important? Are they even necessary? And I asked a question to Charlie Merrill, who is a mind-body informed physical therapist out of Boulder, Colorado, and here is his answer. So the direct question I asked Charlie was, why are manual therapies, such as physical therapy or stretching, still useful when addressing mind-body pain?
Hey, I'm Charlie Merrill, a Boulder, Colorado-based mind-body physical therapist. I like to say I was originally taught to fix bodies using traditional manual therapy and corrective exercise techniques. Think trigger point needling, joint manipulation, and soft tissue mobilization, as well as things like movement and exercise, targeting lengthening and strengthening the body's tissues. Now, I'd gotten quite good at that and had pretty good results for many years, but I realized about a decade ago that something was missing. When I was learning how to dry needle muscles over 20 years ago, the teacher told us a story about a guy who'd been struggling for years with post-vasectomy pain. The teacher said heroically that he cured him in one session by dry needling his low back. Of course, I was blown away, and I eagerly and confidently set out to do the same for my clients. And it turns out this worked some of the time, but the results were really varied. And I wondered, why the inconsistency? I know now that my PT skills aren't helpful for the reasons that I originally thought. About a decade ago, with the emergence of novel pain science, I started to understand that all pain is constructed by and experienced in the brain. This is not a dualistic question anymore about whether you have a structural body issue or pain that's coming from your brain. The brain is always in charge of pain, regardless of the cause. And this means that the psychological and social factors are also always important to address, even after injury or surgery. It became clear that I had some serious unlearning and then relearning to do in the face of this new science. One of the most important things that I had to come to terms with was the fact that the effectiveness of any intervention, including manual therapies, needling, manipulation, exercise, even medication, is a result of the interplay between four things. 1, the patient's relationship with their provider. 2, the patient's belief and expectations about the effectiveness of that intervention. 3, some amount of placebo, basically some effective but poorly understood mystery phenomenon. And 4, real neurophysiologic effects, or easier said, changes in the nervous system. Now notice none of these changes can be directly attributed to muscles, tendons, joints, ligaments, fascia, or other structural tissues in the body. That's because, as I said before, all pain is constructed and experienced in the brain. And while all pain is real, we know pain correlates with fear, not tissue injury or biomechanical dysfunction. Now, is it possible that this guy's post-vasectomy pain was simply neuroplasticity in action, resulting from this interplay between these four things? Now, does tissue injury happen sometimes? And does this weigh into the brain's decision to use pain to protect us? Of course it does. But unlike your car, your body is amazing at healing itself. It's reliable, it's predictable, and you can count on it. So a few months after this guy's vasectomy surgery, his tissues healed. But remember, even in the case of injury or surgery, the brain is where all pain is constructed and experienced. This is why pain often stays turned on long after healing is done, like it did in this guy. Do our tissues, our biomechanics, strength, flexibility, movement quality, the way we walk, and our fitness change sometimes when we're in pain? Of course they do. This guy's pelvic floor function, his muscle strength in his hips, his spinal movement, and his breathing pattern might all be changes that the brain created in the body after surgery. But these changes that we see in the body are just the result of pain, not the cause. See how I flip that? They're an output of a brain that's in a state of danger alarm. Once the brain learns these outputs, they'll often keep running on repeat until we do something to interrupt the status quo. Remember, the brain is where all pain is constructed and experienced. So even if your brain is considering information from your body in its decision to create the experience of pain, it's still only one variable, and it's likely magnified by all the other thoughts, feelings, and behaviors, these psychosocial variables. Now, because I have to rule out the body as part of my process, I examine my patients really thoroughly. Most of the physical findings that I find on exam are either pre-existing or they're just normal findings that are common in people even without pain. Think about things like leg length discrepancies, muscle tension, strength, flexibility imbalances, movement variations, like those sorts of things. When you understand that all pain is due to the brain, the physical changes that I see in the body are not the problem, but rather, at worst, a harmless consequence. In fact, most of the time, those clinical findings don't even add up to a pattern that makes sense biomechanically. This is because the brain isn't very good at simulating a clinical presentation that mimics what I might see after an actual injury or surgery. In other words, after healing has happened, the clinical findings show up as a random assortment of changes when the real drivers of pain are more psychological and social. And the body changes tend to clear up when we get people moving and address those more relevant variables like stress, fear, and other emotions through reassurance and messages of safety. Now, it's possible this guy's breathing, pelvic floor muscle tension, spinal movement, hip muscle strength, they all improved after this basic and non-specific treatment of needling his low back. So this puts manual therapists and body workers like me in a real pickle. I always say that 9 out of 10 of my clients have very real pain despite nothing being wrong with their body. Let me say that again. In my busy practice, in the most active town in America, 90% of my patients have nothing structurally wrong with their body. So do I still treat the body? You bet I do. Why? Because one, people like touch, and it can reduce fear and reinforce safety when it's done well. And I'll get to this in a second. Two, my relationship with my clients depends on addressing the body, even if it's to rule it out as a driver of pain. But more important, it's universally helpful to support people in getting moving again. And three, belief is important. If I harness the person's belief that treating the body can reduce pain quickly, I'll decrease fear and turn down the danger alarm, at least in the short term. Then people have more bandwidth and capacity to do the other work, addressing these psychological and social variables that are, again, the primary drivers of pain most of the time. Because pain is a somatic experience that we feel in the body, doesn't it make sense to use some somatic strategies to change the brain's opinion about what's going on? But the challenge I face every day is that anytime I use body work and movement to address pain, I risk sending my clients the wrong message. Remember, I'm not treating the body to fix it. It's not a car. So how can I deliver, and how can you receive my body work and movement guidance without reinforcing the societal and cultural belief that pain equals a body problem? Even the slightest whiff of messaging in that direction can reinforce the body bias and unintentionally create fear. So I have to watch my language and thoughtfully share my mindset and my intention about why I'm treating the body. Again, because belief matters, I want people to know that all bottom-up treatments are simply a way of having a conversation with the brain in an effort to reinforce safety. Whether the pain is due to the body actively healing, or it's already healed and the person is simply dealing with normal adaptive change and deconditioning from being scared to move, there's one simple goal of manual therapies and movement. That goal is simply to feed new information to the brain that reinforces safety. If my manual therapy input or movement cueing and guidance is well received by your brain and nervous system, your pain will decrease. However, if the brain and nervous system for whatever reason rejects it, even if I think it should help, guess what will happen? Pain will stay the same and even get worse. Sometimes I even use this as evidence that the brain is rejecting body work because it knows subconsciously that it's not the right thing. So what's amazing about body work and movement is that its effectiveness depends on the brain's opinion of whether it feels safe or dangerous. Top-down strategies are generally what cure pain, but bottom-up strategies can be instrumental in getting people moving in the right direction if we do them with the right intention and mindset while keeping an eye on establishing safety. Treating the body and the mind is the most powerful way to intervene. After all, they're intimately connected, right? Remember, when we treat the body, we're treating the results of pain, not the cause. The aim is to get the brain to feel safe so that the body will follow suit. Muscle relaxation, more natural movement, feelings of ease, and less pain. And when we pair this with movement, it further reinforces the ways in which we'd like the brain to change. So if I may, now that you know how manual therapy and movement work, I'd like you to try a thought experiment. Let me ask you this question. Why did the guy with the post-vasectomy pain feel better after one session of needling? Now that you know what you know, why might that have happened? And what are some examples of psychological and social factors that he might have addressed if he needed more support? Please leave your ideas in the comments and let's see how well I shared my big idea here. Thanks so much for watching.